Hello, good morning. Myself Dr. Ravina Kalyan, Faculty of Physiotherapy Department in RPIIT, Technical and Medical Campus, Karnal. Welcome to our YouTube channel RPIIT Academics. If you like the content of this channel, please do not forget to subscribe and share the content. So, in this presentation, we will discuss about the anatomy of the radial nerve and its clinical anatomy. Next is the course of superficial nerve. So it descends deep to brachioradialis, emerges proximally to radial styloid process and passes over the roof of anatomical snuff box. And it supplies skin over the lateral part of the dorsum of hand and dorsal surfaces of the lateral 3-1.5 digits, excluding the nail beds. So these are the motor branches of the radial nerve in arm, triceps and the anconeus, elbow, brachioradialis, external carpi radialis and supinator. Posterior interosseous nerve supply the extensor compartment of the forearm. Next is a clinical anatomy of the radial nerve, in which first is radial nerve palsy. So for clinical finding of radial nerve palsy include patients lose the ability to extend the wrist, finger and thumb movements that are essential for function grasp. In addition, patient loses the grip strength because he cannot stabilize the wrist during power grip. So high radial nerve palsy is defined as an injury proximal to the elbow, wrist, finger and thumb extension abductions are lost if injury is proximal to the elbow and result in the wrist drop. Also, lower radial nerve palsy is defined as the injury to the PIN occurred distally to the elbow, that is peroneal interosseous nerve. Wrist extension is preserved because the most proximal innervated external carpi radialis longus is remain intact. And if the peripheral interosseous nerve is injured, proximal interosseous nerve is injured, proximally extensor carpi ulnaris function may be lost, resulting in radial deviation and wrist extension. And if the injury to the PIN is more distal to external carpi ulnaris, function is preserved and wrist extension remain balanced. Next, the causes of radial nerve injury is humerus fracture, ictalgic, direct trauma, prolonged application of tonic treatment, crutch palsy, intramuscular injection, compression, neuropathy, which is also known as Saturday night palsy. This is the figure of the wrist drop. Next are the lesions of the radial nerve. So at the level of axilla, motor deficit will be tricep weakness and result in the wrist drop. Sensory loss will be at the dorsum of the thumb, lateral dorsum of the hand and the proximal dorsum of the 2 and 3rd finger. And at the level of spinal groove of humerus, there will also the wrist drop and sensory loss will be same as that of lesion at the axilla. At the lesion of radial tunnel, result in the wrist drop and that will be the same as that of lesion at the axilla. Next is the treatment of the radial palsy. First is non-operative. Full passive range of motion in all joint of the wrist and hand and preventions of contracture, including that of thumb index web. Splints used or wrist rope can be used successfully by splints. Internal splint, which is used as Buckler propose early transfer of PT ECB tendon of extensor carpi radiali brevis, and it stores the power grip quickly and effectively since wrist extension is resorted. Thank you.